Morning, colleagues. We are slightly over time, so my apologies for being a little bit late, but people have been delayed getting here. I'm glad you all made it through. I hear from Colin that he wind-sailed here down the street. So, anybody else try alternative transport? I'm sure Transport for Manchester would love to know of these ideas. Right, apologies.
Councillor Gillian Peat, Councillor Linda Gruby, Warren Heppeler, Stephen Pleasant and Zoe O'Neill.
Thank you. For those who don't know, Jill Peat was on AGMA Scrutiny with me for many years, and she's been on here for a while. She's been a great asset to this because she does a lot of work outside of the actual committee meeting. Unfortunately, she's having to stand down here, and I'd like to put on record thanks for the work that she's done. And Colin, do you want to comment on Jill at all?
Well, Jill's been... Sorry, yeah. Jill's been around almost as long as John and I have, I think, in this committee and other AGMA scrutiny committees. But she's always been somebody that you could rely on to sort of get involved in task and finish groups and this kind of thing. When you needed a volunteer, you could always look towards Jill, and she would, she would do her best to help you out. So she will be a big loss, I'm sure, to this committee, and wish her all the best for the future, Chair.
Okay. We'll put that on record then. Thank you very much. Minutes of the last meeting. Anything arising?
Before that, Chair. And I've not filled in the form. Declaration of interest. My daughter works for Oldham, the CCG, so if we can note those. It's a personal interest. There's no conflict.
No. Right. Stephen, you're on.
Right, I should have a set of slides.
Digital.
How do I press this?
You're the IT man, sir.
Oh, yeah. Maybe so. Right, thank you, Chair. So this is a quick 10-minute update on our digital strategy. This first slide shows the landscape of the governance and I guess the digital strategy in a single slide. So top left, that's our governance. We have right at the top, we have a GM Health and Social Care Digital Board. That's our highest level digital board in health and social care. It's chaired by John Rouse and co-chaired by Rowena Burns, who's the chairman of Health Innovation Manchester. We have a sister group in the GMCA, the Digital Steering Group on the left-hand side, and we have various boards report into that. We have an experts network out there, so every single month we bring together chief clinical information officers, chief information officers, network engineers, clinical architects right across the system. And we share ideas, share where we're up to with things, and we try and collaborate on stuff. And there's a lot of our strategy comes out of that group. Back in June 2017, we published our IM&T strategy and we published our prioritised implementation plan. And those are the strategic principles: connect, integrate, collaborate, empower, understand. We're working on all of those. Right at the bottom, the connect, that's really about our infrastructure. The integrate is really about our information. How do we make sure people have the right information at the right time? We have 8 prioritised programmes that we've been working on. And we get capital funds from NHS Digital, NHS England. 2 years ago, 17-18, we distributed about 10 million of capital. Last year, we've just finished, the end of this year, we're just finishing distributing about 6.5 million. I'm going to go through some of those 8 prioritised programmes now. So the first set is all about infrastructure. So if you are a patient and you go to any of your GPs or acutes or mental health, you will get free Wi-Fi today. And when you log on to that free Wi-Fi, you'll get a landing page that gives you a list of all sorts of different apps that allow you to that you can start to access and play around with related to health. We have something called GovRoam. This is staff Wi-Fi. So if you're a GP in Oldham, you can take your laptop and you can go into Wigan Acute, and it will automatically connect to the Wi-Fi, and you can work there just as though you're working from home. So it means that we can start to move services around. The coverage isn't, every organisation's got it, every GP's got it. The coverage isn't always full in every single building, but each organisation's got it. We were the first STP in the country, I think, to complete our procurement for a replacement for N3. N3 is the trust networks that most of our data goes down. They are relatively slow. They're all in the process now of being upgraded. So to the sort of 1 gig, 10 gigs gives it a lot more resiliency. As we get into more services that use videos and images, we will need that bandwidth. And we've been working with, I think we've got 19 organisations. These tend to be your big acutes or GM shared services that manage lots of organisations, have their own data centres, working with those to create an infrastructure strategy, making the best use of things like cloud, making the best use of collaboration, and we're training staff up in how to use some of these new tools, such as those cloud capabilities. Next slide. Some of our clinical systems. This is all for information sharing. We have something called DocMan Hub. We share unstructured data all the way around Greater Manchester. So you tend to think of discharge letters, clinical letters. We transfer, it says 500,000 every month there. It's more like 600,000 every month. We're putting programs into pharmacy, optometry, dentistry now to expand that. We're also going live or starting to work with social care as well as transferring information. This is unstructured data. We have structured data is managed, on the other hand, with the big picture on the right, which is a company called GraphNet. So GraphNet is now, has been chosen every single locality. Wigan are the last ones to take that. And this will join up structured data, so things like medications, problem list, procedures, right across the system. And yeah, we're starting to see benefits already from that. So Rochdale went live with being able to see GP data in their social care just 2 days ago. And with things like GraphNet, now we're getting these consistent tools. You can start to put in things like consistent care plans all across Greater Manchester. So we have the capability to do professional record standards body care plans, which gives us things like condition plans, hopes and goals of patients, crisis plans. They're not adopted yet, so we've got a big rollout and adoption that we have to do, but we have the technical capability to do this now. So the ambulance service are particularly interested in things like contingency or crisis plans for frail patients. Because we had those two major systems there, that helped us, and we kind of adopted those over the last year or so. That's really helped us to win something called a Local Health and Care Record Exemplar bid. This is a little bit of a technical document, I'm afraid, but right on the bottom you can see data sources, your acutes, GPs, your hospitals, mental health, all of your different data sources bought in via GraphNet. GraphNet data tends to be raw data, and we need to enhance that data as well, so we can cleanse it, we can link it better, and we can expose it to different organisations in a better way. So Lycra is all about making much better use of this data. So we're already getting the likes of, sorry, I've gone the wrong way, urgent and emergency care want to be able to use this data, and we're linking so that they can see our patient records. We want to do the same thing with out-of-hours care. We've got something up here called SMASH, which is looking at medications reviews, so making sure that patients are all getting the right treatments. And the idea of Lycra is you build something once and you can reuse it right across Greater Manchester. So we're getting a pull from all sorts of areas for doing this. Health intelligence is a big one that we will end up being able to use this data for. So that's getting into the realms of public health, population health, and ultimately precision medicine. This is an entire story on itself. So I could talk about this for an hour on its own. We don't have time for that. A lot of the stuff that we want to do with Lycra, we also want to do right across the councils. The councils want to join up information for early years, education, justice, transport. So it's very similar. It's convergent evolution, really. So because they want to do similar stuff, a lot of the underlying architecture is the same. So we've joined these two programs together. On the left circle is meant to represent our health and social care. We call it an interoperability hub. You might also hear of it called Lycra. And we're going to use some of that same common components with the wider GMCA area as well, which means we get economies of scale. just a couple more slides to get through. This is one of our other programs, was to create a business intelligence capability. We pull in urgent and emergency care now from right across Greater Manchester. We have an urgent emergency care hub. We can see how hospitals are performing at any one time and how the system is performing. And that capability is rolling out into an entire health intelligence strategy as well. A couple of our major risks. Information governance is a big issue for us. We really have to nail that if we're sharing information around Greater Manchester. Human resource as well is a bit of a limiting factor for us. And that was what you've done through is a quick canter through our previous strategy, those 8 major programs. This is what our future strategy is looking like. So we have a big focus on information sharing, big focus on infrastructure, big focus on information governance. Urgent and emergency care has its own program. We're looking very closely at population health and social prescribing. And with the 10-year plan, we have a whole program with primary care that we need to develop. This is in a very early stage at the moment, this strategy. And finally, we are just doing a strategy review currently. GMCA are refreshing their strategy, and we need to make sure that health and social care digital strategy also lies and nests under that appropriately, so that GMCA, the Health and Social Care Partnership, and actually Health Innovation Manchester, that we are all working in the same direction and collaborating together and not duplicating and building off each other's work. Thank you.
Thank you very much, Stephen. Any questions? Margaret?
Is there a protocol for getting patients' consent for their information to be shared in this way?
Yeah, so there's a whole IG. At the moment, each locality has been working that out themselves and managing it. We're now having to pull all of that together, so that because patients cross boundaries all the time, so we need to share that information. There is an entire IG group that's looking at that. Consent is extremely important if you want to do anything for secondary care. In fact, I don't think you can do anything for secondary care without consent. If it's for direct care, then it's GDPR. You want to avoid consent. The GDPR has a very specific meaning for consent, and actually you get into patient preferences as opposed to consent. So there's some subtlety around that, and we're going through all of the issues of trying to really understand all of that side of things. But you need to get an information governance professional to explain the differences between GDPR consent, common law consent, and all of the other issues around that.
Correct me if I'm wrong, Margaret, but I suspect you, like a lot of us, are worried about your information going to third-party sources. Bear with me a sec. Whereas what this is talking about is what we've said here on many occasions, is to have that information accessible from Tameside to Wigan, from Hope to Oldham. This is not external, this is all internal registered.
Yeah, so everybody thinks that it's the NHS, don't they? But you need to, quite often, if you turn up to A&E, the A&E won't have access to your GP information. If you're unconscious, you don't want to have them making those decisions without having all of that data. So.
Yeah, I understand that, and I know it works. It's worked very well for me. But my concern is where local authorities and social services are involved. Surely there has to be consent for transfer of that information.
If you're going to share any information from, so what you don't want to do is the Department of Work and Pensions using your healthcare data to make certain decisions without having that really scrutinised and understanding what those use cases are. So we don't intend to share data from health out to GMCA without very, very specific use cases that have been tried, tested, that have had public consultation, that we know that we're comfortable with. Yeah, so we've got to be very careful with that side of things.
Thank you, that's really interesting. Is there a strategy for public inclusion with digital interfaces? We're becoming digital by default, but not everybody has the capacity or the knowledge to be able to sort of engage with digital platforms. I mean, I'm a healthcare professional myself. I can see the benefit of them tremendously in terms of disseminating patient information, people being able to access their own clinical data, prescriptions, things like that. How are we encouraging people and enabling people to engage with that more? Thank you.
So the first thing, yeah, we've got to be worried about digital inclusion. I don't think that should stop us from pushing ahead, because if we can make the system more efficient, we've got more people to cope with those who aren't haven't got that digital inclusion. There are workforce programs across, particularly inside GMCA, I think, that are looking at those sort of issues, more so for GMCA than in the Health and Social Care Partnership. We're also looking at our workforce and making sure that they're skilled up in these sort of things. But yeah, we're concerned about it. I think GMCA are doing more work than in the partnership on that side of things for digital. It's something that we probably have to do a little bit more closer look at, and public inclusion as well.
Do you actually involve service users and carers when you design? Do you have a sort of a carers, a service user and carers group that helps to inform maybe some of the rollout of this at all?
We've got a comms group at the moment, and we are developing a strategy all around the service user understanding of that, particularly from the IG perspective. Each of the localities, I think, has their own public engagement and public informing what they're doing on an IG perspective. But as we develop that right across GM, we need our own.
Right. How can I find out more about that in my own locality?
Or which locality you're in. We can point you to the right people to talk to on that, I think, but we've got our own comms department, so we can point you to a lady called Laura Rooney and work out how that's done. Okay,
thank you very much.
Thanks very much, Chair. Yes, I'm a bit not. I think I know the answer to this question, but I mean, the thing is, isn't it, that all this stuff's moving on so fast. The minute you've invested in a system, it's outdated in 6 months' time, or it needs upgrading and all the rest of it. So it's a constant learning process, and that's for the experts. And for those of us who aren't experts, we have to trust you, basically. So what I'm asking, basically, is reassurance, not just on data sharing, which Margaret mentioned, but actual security. I mean, it's not just the DWP you don't want getting hold of this data, it's the insurance companies. So I'm hoping you're going to give me the answer I'm expecting. Can you reassure us that the security systems are going to be adequate?
Yes. Yes, I know I am, unfortunately. We have IT and security work streams on the LICRA. We are audited externally for security. We have our own security officer that works on this, so we take security in a very big way. So yeah, we're doing everything we can to make sure this is secure. So, you know, I want to. So, yeah, all the cloud means is this is stored in big servers, and actually the cloud is often more secure than private organisations managing it can be, because they've got the so you've got the power of Microsoft, haven't you, in their cloud, or the power of Google, and they're putting all of that effort into protecting this information, making sure they've got the latest software, the latest systems.
Right.
Thank you, Chair. I think Stella's probably covered most of it. If one part of the section fails, is the rest protected, and would that still be operable?
So that's a question about resiliency, isn't it? So, and that's one of the reasons, and that's a very complex, because this is there will probably be single points of failure in the system. We have to build a resilient system to try and minimise all of those. I couldn't say hand on heart that there isn't a single place where the thing will break and take it down for a few hours, but we are trying to design it with resiliency right from the ground up. So,
Stephen, I was actually going to use these microphones as an analogy. Each of these are set up that if one of them goes down, although they're in series, they're also parallel. If one goes down, it will bypass that, and the others will be able to continue. Whereas we have had instances, where something's happened in a trust, and you know exactly what I'm on about, and it's blocked everybody else out. Whereas really, if we had a system like this, it could have been isolated in that trust. So, comment, please.
So I guess you're talking about the WannaCry virus, are you? Yeah. So actually, WannaCry was. This isn't my specialist area in this, but as I understand it, WannaCry was propagating through all of the networks, and one of the first things that most trusts did was almost a self-denial of service, by they pulled up their drawbridges and stopped communications going out to try and prevent that, which means that you fall back to telephones and those sort of things. So yeah, we're trying to design systems all over the place to cope with this sort of stuff. One of the results of WannaCry was making sure that everybody was patched up to the latest version for all of their software to protect them from that. But it was the origin of the problem in the whole country, not just the NHS. Yeah.
All right, I'll rephrase it.
That's correct, but we were so that's monitored quite closely by NHS England now, and by various other security organisations that generate regular reports. So every organisation has to keep up to date with their software. And GM wasn't particularly bad compared with the rest of the country either, so we were relatively good.
With the greatest respect, it doesn't. I don't care if everybody else is bad. I'm interested in how good GM are. Yeah, look, Stephen, it's not funny.
No,
there is a bill in the full report. It talks about a total of £34 million, and for that, I think we need answers to these questions. Eve, you've been delayed. This is on the digital strategy. Have you got anything that you actually need to ask about?
No, I listened to where you got up to.
Okay.
Colin.
Okay.
Thank you, Chair. Most of the questions appear to be relating to the public face, as it were. I think it's fair to say that whilst we understand the principles, the detail is probably beyond us. We are not technically orientated, as it were. And I sometimes wonder whether we need a dictionary of IT. We definitely need a dictionary of health and social care, for sure. I think we might also need a dictionary of IT and communication to go with it. But I think what we're also interested in, you mentioned at some point that you are now looking at systems whereby you combine with local authorities, and one of my issues will be how that's being funded. Is that being funded through this £34 million budget, or are all the various district councils being asked to contribute to this programme in order to ensure that it integrates effectively, and so on? So there are some big issues, and of course the bigger the system, and it's going back to Ray's question, as it were, about the possibility of part of the system crashing. How will this knock on onto local councils and so forth if parts of the network should collapse? So that's one issue. But I think back to the public face, the people who are going to be using this are the GPs and the health professionals, and of course the patients themselves will be looking to, as Margaret suggested, will be looking to access their information. So is there going to be some handbook guidelines that enables people to work through this system rather than have to pursue a trial and error system whereby they're sat in front of a screen with perhaps no assistance? Is there anything there that will enable them to know which buttons to press? For example, otherwise your confusion reigns, and what they then do is give up on that and go, right, I'll go and see the practice manager or whoever it might be in order to get the information. So pressure builds up in other parts of the system because the system becomes inaccessible. So I wonder, if you might be able to address those kind of issues.
Colin, are you talking about the public or the professional?
Well, it's both, isn't it? I mean, that's the interface is between the public and the professionals.
Yeah, but I'm saying about logging, I wasn't sure because there are two sides to this.
Well, there are two sides, but of course the professionals obviously need to understand the system to access it, and of course the patients also need to understand how they can access their information, etc., without being compromised.
Stephen?
So there were multiple questions in there, weren't there? The first one I think was all about finance. So, and I can't spare. I remember this is health and social care that we're talking about. It's not the. I can't talk about the finance for the GMCA. We'd need somebody else for it there. Most of the health and social care side is funded by the LICRA fund, which was $7.5 million that we won last year. There will be some extensions to that using various digital funds that we have. Ultimately, we have to be able to show benefits. We have to digitally transform certain clinical pathways. There's a couple of pathways that we're really focusing on at the moment, which is frailty and dementia, and we'll be working out what the benefits are in those pathways. And hopefully that becomes self-sustaining because we're making efficiencies elsewhere. We have yet to determine that as a long, complex process to determine. What was your other? The other one was all about patient access and training, and so Yeah, I don't have some great answers for you for that, I'm afraid. I mean, we are already, you as any member around this table can get access to their GP record by going online to get it today. Apps already exist for that. There's something called patient access that gets your EMIS data. There's a company in Manchester called Evergreen that gives you access to that data, depending on your GP as to how much of that data you get access to. Sorry. Yep.
I'm sorry to interrupt you, Stephen. How many of you have actually logged on for a prescription or an appointment?
I've logged on for an appointment, but prescriptions aren't available yet.
Yeah, okay. It's called patient access. It is intuitive. You know, I appreciate what Colin's about learning about it, but the GP surgery is how most of us find out. You know, it's saying you can now access your appointments and patient, and they have to give you a registration number. But I would actually ask you, as people who are Health Scrutiny Committee chairs, to actually have a look at that, please, because it will help you spread the word out amongst you. Margaret.
As Sophie said earlier, I'm a carer for my disabled daughter, and the difficulty I've had in accessing her medical, because she can't read or write or sign anything, getting access to her medical records is an absolute nightmare. Getting medication for her is an absolute nightmare. So we need to address those kind of issues.
You're absolutely right. Those are the sort of things we really want to solve. So, you know, we haven't got there yet, and I think that already with some of those tools out there, you can start to delegate access between different people. So you should be able to. That's right. Yeah.
If you see the practice manager, Margaret, they have the authority to give you the log on for your daughter's information.
We've got there eventually. What I'm talking about is a journey. The receptionist resisted us. Even though the GP had given his consent, there was still great resistance to this happening because the receptionist didn't think it was applicable. I'm just telling you it's a difficult journey.
Thank you for that.
Yeah. No, the technology is the easy bit. It's the change, isn't it? That's the real long journey. And that's not necessarily IT people that do that. That's working with the entire system to manage it. I don't think I had any more to add, actually. So we recognise it's a problem. I don't have answers for you at the moment. So, you know, we're clearly not going to be able to train 3 billion people around Greater Manchester in this. Systems have to be as intuitive as possible, and we have to have the wider system that helps with those. I know we've already got Amir Hanan in Tameside could talk for hours about this because he spends a lot of time helping patients access that data already. And we need that capability somehow.
I often come back, Stephen, to the committee here and say, look, as advocates for our residents, we almost have a duty of helping them. This is, you take a role to come here, you've learned something. We do have a duty to try and inform our residents about this. As I say, in most cases it is intuitive, and Stephen's used the word as well. But unless you have that comfort and confidence that you can just log in, and it's worth nipping down to your GP, introduce yourself and say, look, in my region, or go to the CCG, they will help even more, and say, help me, help my residents. Because that way, the 2.8 million that we're referred to can be accessed, and that's part of our role. Stella.
Just a little, it's just to that then, Chair, because anybody who hasn't grown up necessarily in the digital age and has had to learn it later, the things that you use every day, you get used to. But a lot of people do use the health service almost every day or a lot of the time. But then there's a whole swathe of the rest of the population that maybe don't go to the doctors very often, and they don't need an appointment very often. And when they do, they've forgotten how to do it because it wasn't something that they did every week or every month like you probably do, Margaret. I know I forget how to use bits of IT if I don't use them regularly. And it might be an idea to sort of suggest from the centre some kind of training scheme that's, I mean, a notice in the GPs saying you can now access your data online isn't any help if you're a busy person and you're not ill at the time. You need to go on a little course somewhere, and maybe we in the districts need to help organise that.
Stella, do you know, that is a brilliant idea. What we did in Wigan was put notices in the chemists.
Yeah.
Because even if people aren't going for an appointment, by putting things in the chemist, people go to the chemist for many, many things. and therefore they pick up information, and it's just a point. Again, it's down to the CCG. Stephen, if you want.
Thanks, Chair.
No, it's a good idea. Trouble with these training courses, they tend to be one-off, isn't it? And then exactly the same thing applies.
It's just a general point, really, Chair. It's how do local scrutiny committees influence the development of these plans before they're into place? When we come here, we kind of get information about what's already been agreed. But how do we influence from the bottom up? Because I don't know about other scrutiny committees, but we find we get a paper that's been agreed by the Health Board. We haven't a clue what it's about until we get it. So how do we influence is what my question is.
That as local scrutiny chairs, that they should be not challenging, but they have an overview of what's going on, and they have the right of input. And so far, I've not heard anything that says that it has been allowed input at local level.
So our strategy has been built from the bottom up for the most part. But that's coming from localities right across Greater Manchester joining together at an IM&T level, at a clinician level, at a social care level. I don't know how the scrutiny actually feeds into that, but our strategy is pulling from all of the localities to try and bring that up and raise it. I'm completely open to any sort of involvement from local scrutiny committees if we can arrange that somehow.
Okay, I'm going to put on record then a request from the committee to you that somewhere or other, there's contact between you and the local democratic services to say how health scrutiny can interview, speak to, have somebody from your knowledge base approach that committee and they can ask the questions locally. Can I put that on record, please? Thank you. Is that sensible? Thank you.
And is that specifically for health and social care?
Yes.
Okay.
Thank you. Any further questions?
Thanks, Chair. This is a lot of money, and we've talked about some of the risks and reservations about it. I just wondered in the refresh of the strategy whether it was worth reminding everybody why we're doing it and what the benefits are, fundamental benefits of putting this level of investment in, and more sort of specifically what the benefits are for residents. So perhaps some real life examples, case studies that we could put in for how this would actually change people's lives, help them to keep well, because I think most people, me included, will use these sorts of systems if they can see the benefit to themselves. And I think it is very complicated if you're not close to it for people to understand, either, as local representatives, officers and so on. And if we are all going to get behind it and try and sell it to the public and, sort of fundamentally justify this level of investment, we've got to be satisfied that we know that the benefits are going to outweigh some of these risks. And it's just a suggestion that I think your strategy would be strengthened if it did that sell again and fundamentally reminded everybody that this hugely complicated, expensive programme will actually make people weller and make the system work slicker. So.
A very good point, Julie. Stephen is right, because at the end of the day, this presentation is almost an explanation from an IT point of view rather than a user point of view. And it leads in, if I may, Julie, into some of the things. It's all well and good, people like yourselves, knowing how this works. It's all I'm going to say, it's there in all areas now, or majority of areas. When it comes down to it, when I've got a consultant in A, doesn't know how to access, we've got him past the thing about making you have another scan, but he doesn't know how to access the scan that you've had somewhere else. Because they don't seem to have the knowledge or information sharing at nurse level and clinician level about this is happening. And I think that is disgusting. And I know this is on record because I'm saying it, because I really am afraid we spend all of this money, but the idea is that it eases up the patient pathway, it eases up the clinician's pathway at a time when they're under a great restraint from finance. But we're spending it here to save money eventually, and it's not actually getting through. And it's all in good, the partnership saying, yes, brilliant job from IT, but how about the user? Thank you, Julie.
Okay, so everything we do will have will be designed by designed to deliver something for the user right up front. So we will, we
I do apologise. Somebody
That's very impressive.
So yeah, so every one of those is designed for exactly that, to either improve the it's got to be digitally transformative. So we've got to look at that care pathway as a whole and work with those service users, understand what their frustrations, troubles, problems are, and then we have to build that to solve that problem. It's not just even Matt Hancock, the latest health secretary, and the latest strategy is all about you begin with the end in mind, don't you? What is the problem for that patient? What is the problem for that user? You've got to be careful with that, because if you take that to the extreme, then you are building point solutions to solve those things, and you don't get the underlying efficiencies. So Leica is about recognising the underlying efficiencies to deliver those solutions, end user solutions, more effectively. And we can pull examples all over the place. We have hundreds of them. So yeah, absolutely.
I think I'm glowing nicely. Worried about the staff knowledge, we've dealt with that. Things like the patient Wi-Fi. How many of you visited relatives or been in hospital yourself in recent times? In the past, they had, especially their emergency admission, they tended not to be able to communicate with families, etc. By having this Wi-Fi there, in the past, some hospitals charged exorbitant amounts of money for it to be used. So I think it's a very, very positive step from the patient and relative view. So we thank you for that. We've dealt with the cloud. The GraphNet, the question is, why isn't Wigan on it? My own borough, and I find it's not on, according to your slides, but it's not on it.
Oh, they've just agreed to go for it now. It's about prioritisation, where your money is and what your current problems are. Those, if you've got other issues, so Wigan have got a good IT strategy. They know what they're doing.
So we blame Andrew, do we?
Foster. I wouldn't want to say that. No.
Stephen will answer and take action about. We're very grateful for your input, and I'm sure we'll come back and moan about how much it's costing us, but thank you very much for your time.
You're welcome, thank you.
Well, Stephen's tidying up. If you want to get another brew or anything, please do so. We've got the time for it. Right, nobody wants a brew. Okay, Mark, you're on. They don't want to have a quick break. Jane. And I'm sure he'll explain why.
Yeah, apologies from Jane. She's damaged her ligaments. Turn this on. She's damaged her ligaments, so she can't drive, so she couldn't get in. So you've got to stand in. My name's Mark Knight. I'm the strategic lead for substance misuse at the Combined Authority. Prior to that, for 15 years or so, I was a commissioner, or researcher, then commissioner with Salford City Council, before spending a couple of days a week on secondment, and then eventually getting a permanent role. The reason I'm mentioning in that is to emphasise that we spent a lot of time working with locality commissioners, because I still feel myself to be that. And it's very much about how we best work together and share our learning, rather than trying to impose any top-down approach. So we've spent a lot of time over the last couple of years trying to understand how each other's treatment systems work, developing common standards and developing this strategy. There's statistics in the paper that you've got and the strategy itself, and I'm working on the assumption that people around the table will be familiar with the fact that the North West and Greater Manchester consistently feature above average in the statistics around alcohol-related harms. I'm assuming that most people will also be aware that nationally and locally we've seen an alarming rise in drug-related deaths. The majority of those are opiate heroin users, but we've also seen rises in the purity and the number of deaths associated with drugs like cocaine and ecstasy. And alongside that, we've got a range of new drugs that have come into play, most notably synthetic cannabinoid receptor agonists, which you all know as SPICE. So the idea of having a joint drug and alcohol strategy came from the local authorities. Prior to that, we'd had a drug and alcohol, an alcohol strategy for Greater Manchester, and then different drug strategies at the locality level. Everyone wanted to do something that was collective. And you can see from the gap from when the GM alcohol strategy ended to where we are now, how long it's taken us to get to this point. Well, they say the day you stop learning, you're dead. I can assure you, after this, I am very much alive. I've come into this just at the point when health and social care partnerships forming, GMCAs forming, the committees are changing, and trying to chase that round and make sure we're in the right place at the right time has been challenging. But we've done it, and I'm pleased that we have, and we really have tried to involve everyone, including service users, those with lived experience, those in recovery, and importantly, on a number of occasions, the voluntary and community sector organisations. As it's gone round the committees and been out for consultation, I've lost count of the number of drafts I've got, because we've constantly trying to keep up with what's saying, and we hope that everyone that we've consulted will see a little bit of themselves in it. I'm not going to talk much about this. As I've said, we've consulted widely, and our agenda genuinely does touch on everybody's work, and it impacts on all of these strategies. This is our vision. It's one that very much promotes recovery, but it's also very much about reducing harm. Not only just to those individuals that use drugs and alcohol, but also to families and the communities that they live in. Did that just go off? How did that happen then? Pardon? Right, okay. There's very much, within our vision, there's very much an emphasis on early intervention and a targeted approach. That's because we know those people that grow up where there are drugs and alcohol problems in the family are much more likely to go on and develop those problems themselves. There's an emphasis on individual responsibility, but also very much an emphasis on our services and our communities working together. We've spent a lot of time organising and consulting on our priorities, and John Rouse and Beverly Hughes, the Deputy Mayor, were particularly keen that there was an emphasis on early intervention and prevention. Alongside that, in terms of reducing drug and alcohol related harm and building recovery in communities, there's a very strong emphasis on developing common standards for services across Greater Manchester. In terms of managing availability and accessibility and reducing drug and alcohol related crime and disorder, the emphasis is again very much on working with our communities and acknowledging, and these are conversations we've had with the Greater Manchester Police, that enforcement alone isn't going to provide you with long-term solutions. And also, in talking to licensing colleagues, we think there really is a lot to gain from working together to develop common licensing policies across Greater Manchester. We've been out to public consultation, strong public support for the strategy. 92% thought we had the right vision. 91% said that they thought our themes were right as well. They welcomed the emphasis on early intervention and prevention, supporting families. Interestingly, there was quite a few comments about reducing the stigma associated with drug and alcohol use, because there does, from my perspective, there does very much tend to be an othering of people with drug and alcohol problems. But it doesn't take long talking to people that are in positions of influence to know that there's not many of us that, if we haven't experienced problems ourselves, aren't actually that far removed from them among our friends and families. And it's important as well, and this is what the consultation emphasised, is that we harness the assets of those people that have come through those problems, who have lived experience of doing so they were able to promote recovery and build recovery communities. It would be amiss of me not to mention that there were also concerns about whether we had the resources to deliver against the ambition of the strategy. I think that's realistic. It's not for me to make political points about austerity, but you can't function as a government officer without being aware of that's the context in which you work. And I think it really underlines the importance of our public service reform and place-based reform agenda, and making sure that we get our hospitals and our community-based services to work much more closely together to make what we have got work that bit harder. In terms of delivering our strategy and vision, and I'll make sure these slides are distributed in full, there's very much an emphasis on a framework for local authorities and for localities, that emphasis on common standards and about how we best work together and use the best examples from different localities in different aspects of work to drive up the standards across the board. We're not going for anything that's centralised unless what it is we're looking at very much demands it. So our drugs early warning system, it makes sense to commission that on a Greater Manchester basis. In delivering the big alcohol conversation, it made sense to coordinate that at a GM level for delivery in the localities. The treatment services in Salford recently went out to tender, but we joined with Bolton and Trafford to do that tender, and we did that around the common standards that we developed in this work. So the spatial levels, if you like, are those where it makes sense to focus on the local authority, the locality. Clusters where local authorities can come together to learn from each other, and it has to be said to deliver efficiencies in some cases. And those that are at a Greater Manchester level. The point is that I'm trying to make is that we're trying to, where we can, all the way across the board, work at the appropriate level, and we have an implementation plan to support this. So the next steps after here are the Corporate Issues and Reform Committee on the 19th of March, and then, fingers crossed, to the Combined Authority on the 29th of March for sign-off. So I'm hoping that you'll support us. Of course, happy to take any questions and note any feedback ahead of Councillor Boschel from Salford presenting the strategy to the Combined Authority on the 29th of March.
Thank you, Mark. Members, our staff here can only circulate the reports that we receive. I'm not sure, Mark, if you're talking about the actual report, because they've all got that with all...
Yeah, it's the slideshows just stopped short, that's all. So my apologies if that's been myself that's caused that.
The staff can only...
Yeah, well, yeah, I don't know what's happened.
Yeah, but
so I apologise if it was
all the
me.
members have the full reports like this.
Yeah, there's not a thing in the presentation that is not in the strategy. The presentation is a summary.
I used to be a councillor in Manchester 30 years ago, believe it or not. You remember, yeah? I did the Thatcher years. In that time, we talked about housing and repairs. That was the bulk of the work. Now, unfortunately, we don't talk so much about housing. We talk about antisocial behaviour, I would say, and drug abuse. Drug dealing appears to form an integral part of that. I don't think there's many days go by where I don't get a phone call or an email from a resident complaining about drug dealing taking place at street level, in broad daylight, very often, on car parks, and the ward councillors and the council's wider structure looking for ways to address these problems. It seems that we're being faced with a situation where we're trying to do a lot more with a lot less, actually, at this point in time. Not just more with less, but a lot more with a lot less. And somehow pulling all these things, the various statutory agencies together so that they can work more efficiently, more effectively, is a huge challenge. And I'm not sure that we've got the resources actually in the system to do it at this point in time. But when you inform the police of these various transactions, we'll call them, they very often already know about it, but they simply don't have the resources to address it. You talk to our drugs and alcohol team, and I think we've got 2 in Oldham. And of course, it's impossible for them to spread their resources. In fact, if you spread them thinly enough, they disappear completely, in actual fact. So you are, in a sense, fighting a huge sort of rearguard action, trying to find a way of addressing this kind of situation. You talk to the voluntary sector, and of course the voluntary groups are all fully aware of it, but don't necessarily have the resources themselves to be able to address it, other than perhaps through parenting skills, social skills, etc., where they try and engage. But it's a huge problem. But I think I could probably say that we're all very keen to try and find a way forward, to try and find a way of addressing this problem. It is a huge social issue. We've talked about legalising drugs, for example, or certain drugs, not all drugs, but legalising cannabis, for example. It's now, for medical purposes, it's now available, and so on. So there maybe needs to be a rethink in terms of how we might approach this, not just across GM, but right down to street level, local level, as to how we take this forward. And I think it's going to require a huge combined approach, a huge effort on the part of all the various partners in order to achieve any significant progress.
Well, I can only echo what you're saying. When I first started working in Salford, just to say 15 years ago, I was the research manager. I had someone helping me do the research so that we understood what was going on. In addition to that, we had a young persons commissioner, we had a service user involvement officer, we had someone whose job it was specifically to focus on criminal justice, and we had an adult commissioner, and we had an alcohol coordinator, so that they could actually properly tackle the problems. There was a big investment made in drugs and alcohol, and prevention work, yeah. Now, the commissioners for drugs and alcohol are often commissioners within public health, who also have commissioning responsibilities for other areas of work. I'm currently conducting a review of our services across Greater Manchester, and all the commissioners I'm going around and speaking to are saying the same thing in terms of there's not the resources or the expertise that they once had to call on to really start thinking through these really tricky problems. So I'm sorry I haven't got any answers, but it's, yeah, just to echo what you're saying.
Okay, 2 points, Mark. I really am interested in the alcohol licensing solutions that you might have. You know, Councillor Warmesham really does try to restrict, you know, alcohol sales and their outlets, but is caught by legislation. So if you could expand a bit on how that might be approached across Greater Manchester. And the other thing I think, which is an omission, is prescribed medication for elderly people, because I myself have I've got it's just an example, a trapped nerve in my neck, and I was put on I've forgotten what was put on now, but I ended up feeling like a zombie, and it took me ages to get off it. And all the doctors were saying is, oh, I can give you more painkillers, more codeine tablets. We've got to look at the prescribing of medications, especially to older people as well.
To answer your question about the licensing, at the moment, as you'll be aware, the individual local authorities have their own statement of licensing policy. Some are more thorough than others in addressing health concerns. And I know the process sometimes of trying to influence in licensing varies across localities as well. So what we would like to see is a Greater Manchester statement of licensing policy that addresses all the progressive measures that there are. And I know it's a struggle with the legislation, but to give it our very best hit. And then for local authorities to decide which bits they might wish to opt out of, rather than trying to get everyone separately to opt into all the different measures. So that's the approach that we'd like to take with our licensing colleagues. In terms of the prescribed medications, there is mention of it there is mention of it in the plan, in the strategy. And in our implementation plan, specifically in the first year, we want to look at prescribing policies and what's available for those that do develop problems. So very much take on board what you're saying, and it's interesting the drugs that you mentioned that were prescribed, because they're in a far less restrictive system in America. They're precisely the type of drugs that have driven them to the problem that they've got now. Yes, absolutely.
Okay, thank you. A couple of points really. I think the strategy around early intervention is really important, and I think thinking about the sort of even wider determinants of what drives people to, I mean, I can't oversimplify them, but what drives people to addictive behaviour. You know, is it poverty, poor housing, lack of educational opportunities? You know, there's a whole holistic picture, isn't there, around what drives, and I guess this strategy needs to be sort of woven into that, doesn't it, really? Yeah, and I think that the vision sort of incorporates that. And the other thing to think about, you mentioned about sort of local and sort of micro drug dealing, is thinking about the sort of macro drug supply, isn't it, really? You know, we live in the northwest, we're in the port of Liverpool, vast shipments of drugs that come in, you know, through those sort of ports, really. Thinking where does this strategy tie in with enforcement? And again, I totally understand what you're saying. We're working in a very constrained context of austerity, where police and all our sort of like border enforcement and things like that are constrained, aren't they, by cuts and austerity? But where does this strategy fit in with that as well? So two little bit wordy questions there.
No, you're absolutely right in terms of those wider determinants. And when I'm asked to explain my feelings on this, I just explain it in terms of, if I were to develop a heroin habit, I'd like to think my friends, because I've got friends, would say to me, Mark, what are you doing? Look at your family. Look at the nice house you've got. Look at the job you've got. Don't waste it. And that's it. Jobs, friends, family, someone to love, something to do.
Absolutely.
If you've got those, the chances of getting over a problem are a lot easier. And unfortunately, there's some people that haven't got those things. And that's the heart of the problem. It's not why, it's why not.
Yeah.
And that's why they're sleeping on our streets. Sorry, personal opinion there. I'm not sure if I'm supposed to do that. In terms of the higher level drug supply, we do work closely with the police, but I don't think they tell me that level of detail, but we do know that's going on. Where we do have a close work with them is around our drugs early warning system. So in the event that we hear about a new drug or a particular batch of drugs being strong, the police are able to get their hands on those and send them over to Manchester Metropolitan University for testing. So over the last summer, where there was a death reported in Greater Manchester due to ecstasy, tied in with some that had happened elsewhere in the country, the reports of the ecstasy that we'd got tested was showing that there was particularly high strength, and we put a warning out about that ahead of Park Life. Similarly, there's just been a warning that's gone out to professionals, not to the wider public at this stage, around different strains of spice that have just come out elsewhere in the country. It seems that it's impacting on the users of it. The reason it's important to know there's a different strain is because there's not cross-tolerance to the different types of spice. It's a very difficult problem because you think you've got one thing roughly under control, and different agencies have developed tests for it, and then a new strain comes out that they can't test for, and we have to start over again. But the Greater Manchester Drugs Early Warning System is recognised as the best in the country, and I'm pleased to say we do have a very high level of close working with the police around that and the type of statements we make around drug-related issues.
Mark, your answer there is brought to light something else. You heard me say earlier on about how we as chairs have to go back and we act for our own authorities. At a date we can discuss later, it would help if you came back and possibly shared more about that knowledge base. I think everybody knows to an extent, somebody imports drugs and then it's split up and it's sent on, and that's when you get the variation in strength. But it would be helpful if somehow whether you can fit into one of our meetings to raise more knowledge about how this system works and why you have these difficulties. Does that make sense, guys?
Yeah, I'm happy to come back discuss with colleagues exactly what you'd like me to put forward in more detail afterwards. I'm more than happy to come back.
But what Mark said was absolutely right. Without naming, all I can say, because we're on live feed, it's not GMP, but I know for a fact that 38 people from Eastern Europe went to Crown Court as a big organised drug bust. And I know this isn't hearsay, this is people who are directly involved with both the investigation and the taking to court. I'm trying to get the correct word, but when they were actually taken to court. But that's just one incident. But those 38 people were the people who bring it in, and then behind them they had people who were on the corner. Between the questions so far, we've got many more waiting. If there's no profit in it, there isn't anything for them to spread it with. And I'm sure that's something that Mark's balanced out on many occasions. The reason they now hang out on street corners outside schools is because profit, no other word for it. Stella, you are next.
Thank you so much, Chair. Yes, and I take on board everything Mark said about the people who are going to end up on our streets and they haven't got a job, they haven't got education, they haven't got any prospects, maybe not have, they have family or anybody to love. I just wanted to focus for a moment on the young people who basically are, you cannot prevent teenagers and young people from risky behaviour. It's part of growing up. They're going to experiment. And whether it's with smoking, drugs or alcohol, the only way to reduce it that I can see is to just give them very lots of other stuff to do. But even that won't work entirely. And our youth services have been decimated. I mean, it's not just poor children, of course, who turn to drugs and alcohol. It's the middle classes, it's the people at private schools who've got money, and so forth. And is there any... Obviously, your early intervention stuff, it's mentioned that you're going to go into schools and all this kind of thing. But all the warnings in the world won't discourage somebody who thinks it's cool. So are you going to sort of try and find some innovative ways to make it not cool, if you know what I mean? That it can be sort of seen as a loser's activity rather than as... rather than as something exciting and new and dangerous to do.
The chair's right. If I knew the answer, I would be a millionaire. No, it's so many different facets to it. We know those people that are most likely to develop problems in the future, and I'm not just talking about drugs and alcohol problems, but a whole range of different problems, whether that's through to self-harm, mental health issues. It's far more likely to occur where you've got a family where there's heavy-end drug and alcohol use going on. And we know they are, and we can target those people, and we can try and reduce harm. And even though we know we've had cuts to our youth services, we've had cuts to our drug and alcohol services, there is still that focused activity. I think you're right as well that young people, if we try to pretend that they don't drink and take drugs, we're obviously fooling ourselves. And that's why I think it's really important that we tell them the truth. You mentioned, can we have a campaign that can try and make them feel like losers, which is a great idea. But there's been examples of that in America where that's exactly what they've tried to do, and it's had the absolute opposite effect. Because so there's a whole academic discourse about the impact of drug warnings that go wrong. I think the bottom line is that we have to tell young people the truth. And I'm not for one moment advocating that young people should smoke cannabis. And I'm not saying that people with predispositions to mental health problems would have them accentuated as a result of smoking cannabis. And I'm not saying there's some people that didn't have any mental health problems, smoked cannabis and did develop them. But those are very small in number. So if you would turn around and say to young people, if you smoke cannabis, you're going to go crazy, and then it doesn't happen, and then you turn around and say to them, but whatever you do, don't take crack cocaine and heroin because that's really bad for you. And watch out because the ecstasy is really strong at the moment. They're not going to listen to you because you haven't told them the truth in the first place. So it's very complicated, but you have to be honest.
Could I just add to that I was very fortunate in a sense that my children, who are all in their 40s now, when my third child was 18, one of her best friends died after taking 2 ecstasy tablets at his own 18th birthday party, and that sort of shocked that whole little community of sixth formers, and I think it sort of affected them and all their friends, and for the good, although it was a horrible thing to have happened. I mean, it's a long time ago now, but that sort of shock is not something you can give to everybody, and it's very difficult to know. As you say, you try the shock tactics, and sometimes they're counterproductive, and so it's just a matter of doing your best, I suppose, isn't it?
But we do tell people that people are dying because they're taking ecstasy. There's this misapprehension out there that it's because dealers are cutting it with things that aren't ecstasy. The vast majority of deaths, as far as we can make out, are because the ecstasy is so strong. So to understand it, you have to understand what happened with the new psychoactive substances that came out, the ones that used to be legal that aren't anymore. So you had a period of time when ecstasy and cocaine were very, very low purity levels. These, what were called legal highs, were a reaction to that. So people started buying that instead when they could from the shops. The reaction of the illegal drug producers was to increase the strength of the illegal drugs so that they could compete. So we're now at the point where cocaine and ecstasy are higher strength than we've seen for years, ever, as far as I can make out with ecstasy. So one pill could be enough to kill someone. So the harm reduction messages that go out with that, if you are going to take ecstasy, just take a little bit of a pill and wait for a period of time before you see whether it's having an effect. Now, those messages aren't something that the police can put out, but the police don't want people, because they can't advocate that people take illegal drugs. Of course they can't, they're the police. But they don't want people to die. So what we try and do with our early warning system is to work with the police, but when the information goes out like that from a health perspective, that's via health. And when the police put out a statement around what's going on, they refer people to the health advice.
It's all right. The advantage of slipping down the list is that everybody's questions covered what I had to say, really, which was, so yeah, certainly in terms of the licensing, I think that'd be really good to hear, and the macro, micro, and as someone that was brought up, raised by an extended family of youth workers, definitely I was raised in a culture of speaking the truth and hearing them speak the truth to young people, and I think that's absolutely right. We're missing that because we've had our youth service decimated, along with all the other services we've heard. So I think, you know, I can make that critical point that there is no coincidence that we've had 74% increase in drug-related mortalities in Greater Manchester in 10 years. 74%, I mean, that's horrific. And that is because we've had 10 years of austerity in which we've seen all those things that we talked about, from housing to employment opportunities to skills to youth, services decimated. So I absolutely welcome the strategy, and I think that line in terms of it's everyone's business. It is, and we're definitely not there yet, are we? So that's words on paper at the minute, and it's how we translate that into action. So I was with representatives yesterday from the Manchester and the Greater Manchester Homelessness Partnership and Network, and it was interesting that, I think that's a great model of partnership working, which, it sounds like, in terms of the conversation around co-production and making sure we've got people with lived experience that are leading and shaping these solutions. It's good that we have these great models in Greater Manchester to draw on. It was interesting that they were saying that drugs and alcohol still remain the elephant in the room in lots of their conversations. So even in that space, they're still saying because of the level of stigma. So, how do we, in speaking the truth and addressing the stigma, there's a huge challenge there, isn't there, really, in that communications, and a lot of work to be done. And that really, I guess, hit me yesterday in that room, thinking if they're still struggling with that, we've got a long way to go. So anything more you can say about that question, really, of the stigma, would be great.
It's a tricky one because we censor ourselves. So I've been at meetings in Salford where I've censored myself in terms of what I've said. And then, without mentioning any names or anything like that, I've subsequently had members of staff that have approached me to talk about members of their family, and talking to counsellors as well about experiences from their families. So I guess it starts with us, really. So and unless we're prepared to be open and acknowledge that, we've got trouble elsewhere. I don't know what to say beyond that, I'm afraid.
Council level is when cuts are done, preventative things are cut. before things that statutory that have to happen. So the preventative work that's done in stopping people getting into these situations, I know I'm preaching to the converted, are so important, and this strategy, anything to do to help that is absolutely welcome.
Ray.
Thank you, Chair. Again, most has been covered. I welcome the strategy, but it seems to me always to be so fragmented because it's a national problem, and there should be a strategy for the whole country as a whole. Around the country, as I do, and they're all discussing the same things, all using the same officer time, all putting sort of like plasters over the cuts. For me, I just wonder, if there was any thought that went into what the Portugal strategy was, in that they legalised the drugs, but prior to legalising certain drugs, they put the clinics in place. So then they could monitor the people coming for all the free drugs, but they knew who they were being weaned off, and I know for a fact on the reports I read, the crime reduced by 90% in the first 18 months. It reduced. And I just wonder if there's a greater strategy for the country, not just Manchester. I'm a school governor, and I always remember years ago the police came in with a suitcase of drugs, and they explained to the kids what these are, what you shouldn't have, and what have you. And you could argue we've educated those children, but what frightened me at those meetings, which I joined in on, a good few years back now, was 6 out of 10 kids knew where to buy the drugs. I had no idea. I'm an adult in the wider world, didn't know where to buy. But the kids knew where to buy it, and that frightened me. And it really hit home in Haywood, where I'm a local councillor, when we had an ice cream van selling drugged-laced ice lollies to get the kids addicted to it. So I think there's a bigger thing here we need to stop. And I hope Manchester's strategy can go a step further nationally and look at the wider world. Thank you, Chair.
A bit more. Okay, there's nothing in this strategy we would disagree with. It's all eminently right, proper and sensible. But without, exactly as you said, national action, minimum pricing of alcohol. What the hell is going on? Exactly. You can buy chemical cider for cheaper than water, and that is nonsensical. Comments about Portugal, absolutely right. Legalise cannabis, then you can tax it. Absolutely. And you can get money, and it's bizarre, absolutely bizarre. But at the moment, comments earlier, for the young kid with no prospects, no hope, drug dealing is the way forward. And until we change that, nothing's going to alter.
I agree.
Your comments, basically all fit in line with each other. But as Mark said, it's taken all this time to get it from local authorities to a GM policy. If you extrapolate that to a national policy, God help us, it's only by us saying that we want action, the partnership. Michael could take back to the partnership. These lot are a bit upset about this. We need to get the rest of the country on board, because there are people in other regions saying the same thing. So let's start talking to each other. Keith, Ray, you'd be a very, very brave people. Whatever we might think, and again, as I say, we're on live feed, whatever we might think, if you're brave enough to go out there and stand up at a community meeting and say, I want to legalise some of these drugs, you're going to be very brave. We might think it's a way forward, because if you take the profit out of drug dealing, it reduces. If you think about it, if you imagine a tree, the real money is made at the top, because it's the feedback. It's like the ultimate pyramid selling. And the people at the lower levels have to find new clients. But if there is no new clients for them, now I'm talking about more the softer drugs, and there have been many people who have been brave enough to say what you guys said, and Colin intimated as well, that if we get these things legalised or nationalised and taxed or whatever, the money that was there, that's been spent on prevention and crime that comes out of it, bless her, but my wife was a magistrate, and one of the main things she dealt with was people thieving in order to sell stuff to buy drugs. And, I think the classic case was 2 £5 packs of bacon. How anybody can walk out of a supermarket, a well-known brand, with 2 £5 packs of bacon stuffed down their joggers, which were produced in court as evidence. And what they got was 1 day's fix. But the impact, the police, the court, the public, is horrendous. I think what Mark and his team are doing is well met. However, Mark, although you think they're saying nice things, here comes the bad things, or the concerns. On page 49, you talk about how you went to the stakeholders. You did a consultation over 12 months, I think it was, for the stakeholders. Yet when it came down to the public consultation, I'm quite horrified that it started on the 12th of December and finished on the 13th of January. Do you really believe that is the time to start talking to the public about these things over Christmas? I don't know if you've noticed that, guys, but I don't think that's right. Eve made a point about the 74%, which I'd highlighted the fact that we know there's austerity across the country, but some of us are more austere than others. And I find it strange that, you can laugh here, but I find it strange that in GM, not only are these high figures, but we've got a much higher, we've got 396 more deaths than the GM average, or we had more deaths, page 48, from alcohol, and the drug figure was 136 over the period. Now, does that mean we're having more austerity up here? If not, why are we having these? Great, it's a national problem, so why are we getting more people dying up here? Do you have any answers to that, Mark? Or any theories, actually?
Well, to try and answer all the questions that I've just had, I agree with you about the public consultation. It's not ideal. We did go out of our way to make sure that we consult with the voluntary and community sector organisations, both at the beginning and then once we'd started the process of writing, so that they could see the themes that we developed. It also includes the feedback that we've got from service users across those areas when they were consulting as part of their tender processes. But I take your point, it's not ideal to do that over that time period. In terms of the national position, when the government strategy came out, I happened to be at an event with the Greater Manchester Mayor, and his commentary around that was it's all well and good, but where's the extra money, was what he had to say about it, just echoing what's going on around the room here. We are committed as part of the strategy to have a look at minimum pricing and the evidence base around that. With regard to the police going into schools with the drug boxes, they don't do that anymore because all the evidence firmly suggests that it doesn't work. The decriminalisation legislation debate, that's not a conversation that I've had with elected officials, so I'm afraid it's not something that I could... The Daily Mail won't like it. I've my own personal views, but this isn't about my personal views, so I'm not going to give them. But in terms of why it is that we might have more drug-related deaths in this area, it's linked to the fact that we were together with areas like some parts of inner city London and Glasgow, the first heroin wave that came in the 80s hit areas like us. I mean, it's peculiar because it hit most of Greater Manchester, with the exception of Bolton. I don't know why. Bolton came along, in terms of the epidemiology, it came along later in the 90s. But basically, we have one of the oldest heroin using populations in the country, and unfortunately, because of the lives that they've lived and the lifestyles that they've had, it means that they start to accumulate conditions that should be associated with people that are a lot older, and that's certainly one of the factors why we have a disproportionate number of deaths.
Just on the national point, I mean, is there, in terms of the communication, can we take as an action just to write to our Greater Manchester MPs to share what the minutes of this meeting are, or something that at least is making a point? I don't know what, I know Sir Jeff Smith happens to be the local MP who's very vocal on legalisation of cannabis and of drugs, but I don't know about the picture across Greater Manchester. But we do have, we've got this growing family and we're communicating here. Can we have that conversation really? And can we take away where we've got some clear calls?
It's a well-made point, Eve. And I know Colin was on the same lines there. I'm sure that Julia and Lindsay, between them, and maybe Michael from the partnership, can actually think of a draft to copy our MPs in. Michael, do you want to say something about that?
Yes, sorry, Chair. I mean, when you look at the strategy, it actually contains a lot of very specific actions. And I wonder whether, once it's been to the GM leadership, etc., and it's been approved, what then? How do we take it forward? And I think perhaps we may, just following on for what Eve was suggesting, that we need some kind of forum, either at local level or at GM level, to take this forward. And perhaps we started at GM level, because obviously we don't want a fragmented approach, filtering down to each district, as it were. But when you look at some of these, if you just take one, for example, 1.6, adopt a place-based approach, well, that is highly resource intensive. We have 3 or 4 of those running in Oldham at the moment, and I'm sure every other district's got something similar running, but it can only run for so long. And then you have to move it somewhere else, possibly. But I think we need to, if we're going to try and address this problem, we need a concerted sort of strategy that, with all the partners there, in order to look to see what we can do between us, in order to try and find a way forward, if we possibly can. There is no way we can address all of this, but I think we need to pick out those things that we can do, and going back to Ray's point, Keith's point, there are things that can only be addressed nationally, but there are things that we can do in here at a GM and district level that we might be able to take forward. And I think we need to find a way of tackling that sooner rather than later, if this is going to mean anything after it's been approved by GM leadership, Chair.
The fact you said that, Colin, is intriguing, because Ray and Keith and I were chatting earlier on this morning. It's a very comprehensive report. And if you look at the recommendations, do we endorse it? Of course we endorse it. But our concerns, which we mentioned, is what's next, which you've just touched on. There was nothing here that says, really, this is what we intend to do about. And I'm sorry that's putting it crudely, Mark, but that is something that, when we were talking, that was our concern. Whilst you've covered everything that basically we know are the problems, what are we going to do about it? So I would say in July, would you manage before now in July about what your next steps would be?
Absolutely.
Okay, can we put it on the diary, please? Thank you. Thank you. Is there anything further, guys? In that case, thank you very much for... No, so Julie, my apologies.
Sorry, I'll just be very quickly. It was a similar point to Councillor McLaren that we're being asked to agree that the strategy runs to March 2021. So it's 2 years to show some progress on quite an ambitious agenda. So it's one is, are we confident that we can show achievements across all of these? And 2 is, I'm assuming there'll be some kind of implementation plan behind the strategy that will show how we're going to do it. The second point was on the MPs. I can't see them listed in the key stakeholders, whether that's something we can take back to Bev Hughes and others as to whether we engage them as part of the process, as so that we draw that to their attention as we do with other key strategies. And then the final point was just in support of Councillor Stella Smith's point and the focus on how we go about challenging social norms. And as a mother of a daughter, especially worried about young women, and your point that I'm concerned that it's just very fashionable now to drink in excess, and you know, it's seen that, you know, and it's how we nip that in the bud, because that's almost at the thin end of the wedge. It's very fashionable to sort of drink, you know, shots and everything, almost like it was in the 1950s in my mother's day to smoke a cigarette in a cigarette holder. It's your point, it's seen as cool. So whether there's any sort of clever marketing people who can just look at that specific thing, because I think the other is right, but I sort of see that coming across, especially for young girls and women.
Your papers, the next thing is work plan. Well, yeah, we've actually gone through that, so I'll not dwell or ask you to dwell on the work plan. How many of you know whether you're coming back on the committee next year? Pardon? I'm presuming I will come back. Is that a wish list or a threat? Thank you. No, seriously. The committee, the reason I asked that, the committee suffers from a churn rate of about 40%. And it's very difficult. And Julie and I were talking earlier on that we don't know until after all the AGMs. We know some are very early mid-May, but we get as far as June with some of the notifications, and we can't actually plan until we know who we're going to.
The problem is that Chair of Health Scrutiny is certainly embedded with an elected position. Absolutely. So it won't automatically be an AGM of the group, and then
yeah,
there might be somebody else who puts up for it.
Yeah, well, I'm in exactly the same position. I have to do it twice because then I have to rely on you asking you to re-elect me again after. But anyway, sometimes, as somebody said to me this morning, having 40 years of clinical experience does actually help a little bit. But do you understand that? As soon as we know, then we can see what training we need to do. Now, on the subject of training, Theme 3 came to us and said, we need to have dates for your members to have training. We offered 3 potential dates. We did like a matrix, as you know, and then they couldn't fit it in. And we ended up, after a little bit of negotiation, what do we say, because at one point Lindsay was under the hammer a little bit, which was grossly unfair. We agreed that we would take one. I tried, and check me if you think I'm wrong, I tried to put it off until June, because then we wouldn't be doing it twice. No, I don't think the point of doing it twice, but they were adamant. I think there's a list that says they needed to get so much done within a time frame, but I'm being cynical. And so tomorrow, some of you, now I know a lot of people have got jobs and other things, but how many of you are going to the fire to Custody Close tomorrow for the training? No, look, I'm just trying to be very upfront about this. This was the best we could negotiate, and that's the term, is negotiate the date where the clinicians and the admin people could come and meet with us. We will be having a second session early in the new municipal year, because this is not going to go away. I was looking back at my papers from 2014, 2015 on the son of Theme 3 or the father of Theme 3. The slides look awfully identical that you're going to see tomorrow to what I've got on the computer from a couple of years back. But that's the way the NHS goes.
I'm terribly confused because I thought Wednesday, Thursday, obviously I got one of those days wrong.
Margaret.
It might be helpful if people who can't make it,
They'll get the slides.
well, get questions to you that we can raise tomorrow. Because, you know, there are tremendous problems with it.
If you've got a question, email them straight to Lindsay. This is my right arm, literally. And we will move forward from there. Okay? But let's look at the things we've achieved. And one of the biggest, and I'm quite arrogant about this, we spent 8 months banging the table to get data out of the partnership about how many non-UK nurses and how many non-UK junior doctors. There were also, Lindsay at one point was told that the chair can have a report, but you can't show it at the committee meeting. And I know I'm probably, but that didn't go down very well. And we eventually got the figure Now, because we've got it and we've all decided that we couldn't afford to lose another approximately 10% of nurses and 10% of doctors, it went back to the partnership, and then the partnership in turn sent it off down south. And now we know that our doctors and nurses are safeguarded, irrespective of what happens tomorrow and Thursday, etc., because this country is 33,400 nurses short. To lose approximately another 10% of what we've got is obscene. But you guys, by persevering, helped us carry that through. And all I can say is thank you. Thank you very much. This year, and I'm not trying to boost anybody's ego, but this year, we sometimes get Colin's being a consistent member of the committee, but Colin, would you not agree that people seem to have more knowledge this year, and that's very good. People want to engage more from the committee, and again, I thank you for that. Are there any questions, please?
I missed the primary care presentation because I was in hospital.
Yeah.
But if we're looking at theme 3, primary care has got to underpin it, and there doesn't seem to be any connectivity between the two as far as I can see. So it's how we're going to look at...
Margaret, if you'd been a fly on the wall in a meeting with the person who took over from Diane Whittingham, Anthony Hassel, and the person who's running the meeting tomorrow, Jackie Robinson, you will know that there was a lot of table thumping on my part, because it's all well and good as saying, right, we agree we haven't got enough clinicians to have all the specialities in every hospital. So we move them, say, to Salford to Hope for spinal work, or to Wigan for knees. But what happens after that? There's got to be that connection between local outpatient, the follow-ups, and have you noticed how much of a delay there is between a discharge and the GP knowing about it? And we've got to stop that. It's anything up to 10 days before the notes catch up with the GP, and the local nurses have got to do something with that patient. We're spending thousands of pounds doing surgery on patient theme 3, but then we're not catching up with it. And it's only because of the way, I think in a lot of cases, primary care is done these days. The paperwork does actually get to the primary care, but it doesn't actually permeate down to the clinician making the decisions. It's somewhere in that. It's pity Stephen's not here still. So you're absolutely right, and it's something that we are very concerned about. I've said this before. We have a meeting every so often. I spend at least one day a week meeting with these people, and sometimes the meetings aren't exactly overly friendly, because we are there to ensure that our patients get the best possible care in the right place at the right time within the budgets we've got. It's all in good saying there's X pounds, but if we're not spending it efficiently, our patients, our residents are not getting that treatment. So I hope you support that attitude.
I'm sorry to go on, John, but I think the other problem is are interested in patient flows at all, and somebody in one part of our city has to take 3 buses to get to Hope Hospital or Salford Royal. It's just they're just not connecting.
Margaret, that's why, you know, some of this table banging was going on. Theoretically, they are going to be followed up locally. But I had a complaint, and I mentioned this at a previous meeting. A Tameside councillor reported that his wife was having to drag all the way up to Wrightington for outpatient treatment. And that's obscene, because it's not very easy to get to from Wigan, let alone from Tameside. And so, you know, we wholeheartedly, and, you know, Lindsay will, you know, add that to the list of things for us to be concerned about. I don't know, apart from us keep reporting it, and I'm sure Michael will have made notes there that the committee are not happy about the transport post-op. But tomorrow, those of us who go to Custody Close can really bang the table on behalf of the whole committee. Okay?
I've always seen scrutiny, really, as being the job is to ask the questions that an ordinary member of the public who wasn't a specialist and who didn't have any specialist knowledge but had a reasonable, educated idea of what was going on would ask. So I'm not a health professional at all, never have been. I was in education all my life. I mean, obviously Sophie is, so she knows more about what's going on. But basically, sometimes some of the real professionals need somebody who's more or less almost walked off the street to say, but what about? And then to tell them a little bit about what's happening down there on the ground, where sometimes they don't know. So I don't know if you'd agree with that, John.
I was going to say, I don't come to this though as a health professional.
No, I
realise it gives you a
that.
little bit. But I only work in a limited sphere, you know. I mean, the health and social care is vast, isn't it? I come to it just to try and, well, my own interest, but also advocate on behalf of what I think is really important to our residents, really, you know. So that,
you probably know much better questions to ask them. Sorry.
I was just responding to Stella's point, really. But I think we're all here, aren't we, to try and advocate and get the best possible outcomes for our constituents.
Julie. I get my specs after the meeting, you see.
Sort of following on from what Stella said, really, I think we have a bit more knowledge. I'm not sure we have understanding necessarily, but maybe knowledge, because there's an awful lot more health scrutiny, if you like, around than there used to be through care in acute and localised scrutiny, devolution issues, health and social care, etc., health and well-being. So there are sources of information. It's actually making sense of it all that becomes the problem. And I think we're sort of still wrestling with that kind of problem. But nevertheless, I think, as you say, we have a greater degree of knowledge. It's the understanding that needs to come with that, and how we process that information that we're still working on, I think.
Thank you for that, Colin. 18 years ago, it came to two authorities within GM. That was Wigan and Stockport. That's how I first met Warren. I was a relatively new councillor in those days, and suddenly when the leader says, I want you to share this pilot, I said, well, hang on, you know, there's a lot of people. He said, no, but you've got the clinical experience, whereas they've got the political experience. And what we did was put together a committee which wasn't, as you say, just elected. It was about, we took the three groups, the Liberal, the Conservative and the Labour, and got all the leaders involved. So in turn, it didn't become a political fight. They were all there. And Stockport did something similar. We've grown a long way, as Colin said, in that period since 2001. We've gone through two of the biggest consultations in the history of the NHS. They're making it better now, and then Healthier Together. Now we're into theme 3, which is basically Healthier Together under evolved. And sorry, I smile because, you know, as my list, you know, the number of cane sticks I get later on. I think we are progressing. Colin is right. The understanding, as much as the knowledge, is very, very important. And that comes down to you and what you do back at the ranch house, because it's pointless doing it here if you don't take your experience and your knowledge back to your local authority. Because without them working together, we've basically not achieved anything. So thank you very much. Safe journey home.